Okay, thank you, Bala.
Yeah.
Good morning, colleagues. I'll be speaking on the barriers to the use of internal mammary arteries in clinical practice and how do we address them. There is no doubt that the two internal mammary arteries are the best conduits available for coronary artery surgeons. There are a number of features which protect them from atherosclerosis. The histological features include the fact that the endothelium of the internal mammary arteries has fewer fenestrations and lower intercellular junction permeability. This retards the migration of lipoproteins, which, as we know, is the first step in the development of atherosclerotic plaques. The endothelial cells of the internal mammary arteries are rich in heparin sulfate and nitric oxide synthase. They release large amounts of nitric oxide, which again contributes to the antithrombotic properties of the internal mammary arteries. And the internal mammary arteries exhibit the phenomenon of sequiescence, where the intima remodels and the media thickens in response to injury, which again prevents atherosclerosis. So all these histological benefits do translate into clinical benefits, and a number of observational studies over the last few decades have consistently shown that in patients who have two internal mammary arteries compared to patients who have a single internal mammary arteries, there is a mortality advantage and there is a morbidity advantage as well over the longer term, over a period of 10 to 12 years. So in the presence of so much clinical evidence of the benefits of two mammary arteries, why is it that in clinical practice, two mammary arteries are not that commonly used? According to the STS database, about 5% of patients who have coronary artery surgery in the United States have two internal mammary arteries. And in the UK, the corresponding figure is in the region of about 10%. So there are obviously some reasons why internal mammary arteries are not used as often. What I'm going to do today is to look at the reasons why surgeons do not use internal mammary arteries so often, and then try to address them so that we can use IMAs more often. I've grouped the factors that are barriers to the use of BIMAs into 4 categories, and I've listed them over here. The technical factors also include the risk of complications, the alternative options available to surgeons, the atmosphere, the political atmosphere or environment in which surgeons work, and of course the level of evidence. Coming first to technical factors, using two internal mammary arteries takes more time. First and foremost, it is a long procedure compared to the standard operation of LIMA and 2 veins, which is used in more than 80% of patients worldwide. This is mainly because the two internal mammary arteries have to be harvested in sequence, and they cannot be harvested simultaneously, as in the case with the radial arteries or the veins. Using two internal mammary arteries makes the operation slightly more complex. LIMA and 2 veins is a standard operation which is performed in a standard fashion. The same cannot be said for using two internal mammary arteries. And there are a variety of ways in which two mammary arteries can be used, and some of the ways are shown over here. This picture on the left shows two pedicle internal mammary arteries being used. The right internal mammary artery in this case is anastomosed to the left anterior descending artery, and the left internal mammary artery is going to the obtuse marginal artery. Not shown in this picture here, but pedicle grafts can be used the other way around as well, where the left internal mammary artery can be anastomosed to the LAD, and the right internal mammary artery, a pedicle graft, can go to the obtuse marginal artery either in front of the aorta or behind the aorta. Some surgeons use the right internal mammary artery as a free graft, where the right internal mammary artery is anastomosed to the side of the left internal mammary artery to form a T or a Y graft. The left internal mammary artery is then used to sequentially graft the diagonal and the LAD at the front of the heart, where the right internal mammary artery is anastomosed to the obtuse marginals and the PDA at the back of the heart. Now, this setup increases the complexity of the operation by a few notches. Also, using sequential grafts makes the operation technically more complex, and technical imperfections in this case can lead to significant penalties. It's because the anastomosis in this particular setup are not independent of each other. Each anastomosis has an influence on the other anastomosis in the sequential chain. Problems with any one particular anastomosis can affect the other anastomosis as well. And if there's a problem with the Y graft, the flow to the right mammary artery can be compromised, and that jeopardizes the entire coronary tree on the lateral and the inferior surface. Sometimes, very rarely, problems with the Y graft can jeopardize flow in the lima to the LAD graft, and that is the most reliable graft that we know of. Limited availability is another reason that increases the complexity of the operation. The two mammary arteries are the length that is available, and nothing much can be done about it. Compare that to the vein, where if we need more vein, we can always harvest more vein. And this becomes a problem if the short length becomes apparent once the grafting has started, and then if the length is not long enough, the surgeon may then have to compromise his strategy. Difficult coronary anatomy is the examples being when the heart is big in cases of cardiomegaly, or if the targets are very distal, the mammary arteries can be stretched, or there can be tension on the anastomosis. Coming to perioperative complications, perioperative complications are slightly more common when bilateral internal mammary arteries are used. There are some complications which are specific to the use of the right internal mammary arteries. For example, bleeding from the RIMA bed or bleeding from the side branches of the right mammary arteries. These are in addition to any other complications that can happen with standard lima and two-vein operation. The incidence of sternal dehiscence is slightly higher in patients who have two internal mammary arteries. The ART trial, which was the largest randomized trial comparing single versus bilateral internal mammary arteries, showed that the incidence of sternal reconstruction was 0.6% in patients who had a single mammary artery, whereas it was 2% in patients who had bilateral internal mammary arteries. And these complications are more common in diabetics and patients who have COPD and morbidly obese patients. The other problem with bilateral internal mammary arteries is it is very rare for registrars to be doing these operations during their training years, and it's usually when surgeons become independent operators, they start using this setup, and then they go through the learning curve on their own. So these are some of the technical factors which act as barriers to the use of two internal mammary arteries. Coming to the alternative options that are available, if two arterial grafts are better, it makes sense to be using, if not the RIMA, the radial artery. And the radial artery is a conduit that's easy to harvest, saves time because it can be harvested while the mammary is being harvested. It's easy to handle, it's robust, and long-term data suggests that it is better than veins. The radial artery results are better than veins and almost as good as the right internal mammary artery. Now, coming to saphenous vein graft, many advances in medical management of risk factors in recent years means that there's better control of hypercholesterolemia, diabetes, hypertension, which means the incidence of saphenous vein graft atherosclerosis is much lower now than it was 20 or 30 years ago when the observational studies which showed benefits of BIMA mainly were published. The environment in which surgeons work, surgeon-specific outcomes are published for all surgeons in the UK, and the outcomes of interest is only mortality during index admission. Only short-term outcomes are measured. There is no measurement of long-term outcomes. So there is an incentive for surgeons to keep the operation simple and to keep the complications at a lower level. If at all there are any advantages with bilateral internal mammary arteries, that is over a longer term, and in the short term it just needs more resources and more time, and therefore there's no incentive for surgeons to use two internal mammary arteries. Coming to the level of evidence, there are many observational studies which have shown benefits of internal mammary arteries. The data from randomized trials is not as prolific. We wait for the results of the ART trial. The 5-year data has been published, which shows no difference between single and bilateral internal mammary arteries. But later this year, the 10-year data will be out, and we'll see whether that shows any benefit. I'll miss a few slides in the interest of time. Coming back to what are the solutions and how can we increase the use of bilateral internal mammary arteries? I would suggest that we have an absolute median sternotomy, which And if by any chance the median sternotomy is not median, then maybe change the strategy and not carry on with bilateral internal mammary arteries. Set yourself enough time. There is no doubt using 2 IMAs is a longer operation, and we should resist the temptation to giving into demands from theater staff or nurses or anesthetists to finish the operation by a particular time. Increased length can be made available by skeletonizing the arteries. There are 2 ways to obtain skeletonization. One is to harvest the artery as a skeletonized artery. I think that takes a bit longer, and people who have been trained in harvesting a pedicle grafts may find it difficult to change practice. So in my practice, I harvest it as a pedicle graft, and once it has been harvested as a pedicle graft, I then skeletonize it as required. All patients do not require a very long IMA, so you don't need to skeletonize it. But 5 to 7 centimeters can be easily added by skeletonizing it, as shown in this picture over here. There are many ways to use the 2 internal mammary arteries, and the best way is for surgeons starting off, or surgeons who want to increase the proportion of IMA use, to keep it simple. These are various configurations. I think the best way, forget the radial artery over here, but this is the simplest setup, where the right internal mammary artery is anastomosed to the LAD in the end-to-side graft, and the left internal mammary artery is used to graft the OM, again as an end-to-side graft. Coming to sternal closure, 8 to 10 sternal wires is a must if bilateral internal mammary arteries are used, and it's very important for the lower half of the sternum to have lots of wires, because when there's sternal dehiscence, that is the area which starts dehiscing first. We use Colatemp as well in high-risk patients. It is antibiotic impregnated collagen, and we use it in patients who have BIMAs and who are diabetics or have COPD and other risk factors. Coming to the political environment, I do not think surgeons should really worry about that. If the indications of surgery are rock solid and technically the operation is done safely, it should not increase the risk of complications. And of course, during starting phases or during the early learning curve, surgeons should understand their own limitations and progress accordingly. And I'd like to end by saying that reach out and touch perfection in what you want to do most. What else are heavens for? And a serious coronary surgeon should always include the use of two mammary arteries or radial and limas in their armamentarium, so as to be able to do more arterial grafting. Thank you.
So we'll give it after the next one.
Yeah.